Okay, uh, everyone, I am Dr. Steve Rasner, and welcome. I first want to thank Micro and Modern Dental for putting on this tremendous platform to my colleagues. I think it's an amazing platform, and I'm honored to be a part of their educational courses. And so let me thank them, and let me thank the behind people that you guys will probably not get to know, like Medina and Gabriel and Jennifer and Tin, who make this all happen. They work assiduously to get education to you guys. And then let me be very clear that I'm well aware that it's 7 o'clock on the East Coast, 4 o'clock on the West Coast. And I know there's a myriad of places and other things you could be doing right now. So you better believe I didn't come in here for an hour to waste your time. I came in here to make what I believe is a significant impact in a very short time on how you do things in your office, especially surgical skills. But you're going to find out in a few minutes it's even more than just your surgical skills. It's going to add tremendous productivity and interest to what you do each day. So let's get on with it. So let's start with this. What if you walked into your office at 9 o'clock on Monday morning, this patient called you at 8 when your office opened, and they said, I broke a tooth, but you really don't know the extent of the break. And this is what you walked into. How would you approach this? In other words, how do you approach a tooth in the aesthetic zone that's sandwiched in between two other teeth that you don't want to touch? That's a little bit of a different strategy than this tooth. That looks just outright evil if that was in your chair at whatever hour. And why do I say that? You're going to hear me talk a lot about you developing a strategy on every tooth you take out. And if you follow that and you take just 3 or 4 minutes to look at the x-ray, to look at the bone, this patient you're looking at is a bruxer. You almost can get that picture right now from this one little slide, where they have thick bone and long roots. And, our approach, the burrs we're going to use, how we're going to get this tooth out is a bit different than the one I just showed you. So we're going to come up with strategies that we need. I mean, this is very different than you coming in with a patient that has 6 teeth left and they're going to have a conventional denture and you're going to edentulate them. No. In these cases, we have to protect the adjacent teeth. So how do you do that? How do you do all this without having tremendous anxiety, without referring it out, and feeling very, very accomplished when you're done? And, let's not kid each other. We're in long past the period of time when we take teeth out and we don't prepare that tooth for the possibility of an implant, which would bring into the equation atraumatic extraction, leaving all 5 walls and grafting this site. So look, I'm not going to make you wait 50 minutes for takeaways. I'm going to give you 3 takeaways right now in the first couple minutes of this webinar. So here they are. And maybe you know them, maybe you used to know them, maybe you don't. Stop using forceps or relying on forceps to get teeth out. That just is not effective. This is how I was educated many years ago in dental school. It is a recipe for either breaking roots and becoming very, very frustrated, or breaking bone and obliviating the ability to put an implant in without grafting. So the only time that you're going to see me teach you to use a forceps is when the tooth is so loose that you could have gotten it out with a hemostat or something else. And don't worry, I'm going to show you the steps very shortly on how to make this happen. The 10-second rule. If you tune out after this slide and the next, you still are going to come away with some good stuff. This is the whole enchilada right here. Here's what it means. You're going to learn in this seminar that when we take teeth out, we lean on the tooth with an elevator. And you live in a day and an age different than 15 years ago when we only had a set of 4 elevators for most surgeons. Well, today you have a whole new array of shapes and sizes. Luxators, for example, are a terrific, should be an integral part of your armamentarium. And so when you're using the luxator and you put pressure on a tooth, what I have found from the courses I give is that the novice surgeon twists his hand constantly instead of holding torque against the tooth for 10 seconds. And trust me, 10 seconds is an eternity in a clinical chair. It's really hard to train yourself. But as you're going to see shortly in this lecture, what you're doing is you're implementing and activating the phenomenon of something called creep, C-R-E-E-P, where you impact the periodontal ligament and you impact the surrounding bone, and the tooth actually rises up for you if you do it properly. So whatever you're using, I don't want you to use a forceps, but even if you did, and you're not going to listen to me, if you turn it to the meso or distal, whatever direction you're using, and you hold it for 10 seconds, it will, in fact, cause the same impact. In fact, some of you listening might remember, some of you that have been out there for a few years, I bet there was a time in your career when you went to take a tooth out and you did it the old-fashioned way. You rocked it left, you rocked it right, whatever way you did it. And you really were sweating and you took a break because you had to. And when you came back, tell me if I'm wrong, the tooth was a little bit looser than it was when you were there. That's the phenomenon right in front of your eyes called creep. So 10-second rule, put it in your bank of rules. And here's just an easy one. When you're working on the maxillary arch, get a second assistant. I don't care if it's your front desk person, if you have a team of 2, okay? You need to bring somebody back because the thing that stresses you out the most is the lack of visibility. And when you're working on the maxillary arch and your mirror gets soiled in a matter of seconds, whether you're using a drill or whatever it's from, and you have to stop every 5 seconds. I know it doesn't look like a profound rule, but it makes everything go better. So if you have 2 assistants, bring them in when you're doing a maxillary extraction, particularly a posterior maxillary extraction. And if you don't, cross-train somebody at your front desk. So the 4 gems that this podcast is entitled, the first gem is that will impact your surgical skills instantly, is not we're not operating on the wrong patient. The second one is, and you're going to love this one, the gold standard for oral sedation. I almost can guarantee that 90% of you do not know the protocol that I'm going to impart to you in a few minutes. And even if you don't choose to do surgery, it'll be life-changing, absolutely life-changing. And then I'm going to go be specific with my approach to taking any tooth out with the a longer explanation of my summary I just gave you. And then lastly, we'll talk a little bit about, well, what should we be putting in the sockets and what do we put on top of the socket called the socket seal? And there's just a litany of information out there that can, quite frankly, confuse you. So let's talk first about not appointing or you not electing to work on what turned out to be a red flag patient. I'm not going to get too detailed in this, but I do want to give you the obvious, because maybe you don't know. Maybe, should I do this case or not do this case? So I do want to say to you right now that even though I'm going to give you an oral sedation protocol that's going to absolutely blow your mind, there are patients that require IV sedation that you will wish that you never started. Not many. I think I can look at you in the eye and clearly tell you that 95+% of all your patients can be orally sedated under the protocol I'm going to share, and you will be quite effective. But if you walk into an operatory and the patient won't look at you, they're shaking, they're crying. I mean it, like you walk in, I'm talking about your consultation. There's not many of these, I know this, but don't think you can be Superman for everyone. So there are people that if your gut tells you, you're going to hear me say this over and over again in this short time we're together. If your gut's telling you no, then listen to it. Do not go against that inner gut feeling. Because any patient that you cannot manage through either oral sedation, or certainly you can manage them through IV, they compromise your knowledge instantly. Look, I've been doing surgery for 30 of my 40 years, extensive surgery, anything you can think of, sinus lifts, ramus grafts, and all kinds of extractions. There are people that when you're working on them, and you know this is true, that if you think you're hurting them, because I'll get an occasional patient that'll talk me in, very rarely, to not sedating them. Oh, I don't need that. I'm fine. And they get in a chair and they're white knuckled. Their feet are crossing left and right. And even though you probably aren't hurting them, the message is that you're hurting them. And in some cases, they'll move or they'll react, and the whole scenario goes south right in front of you. I mean, if you're doing one extraction, maybe, I got to be honest with you, I take a few minutes to make sure they don't need sedation, because that changes everything. I don't care how skilled you are. This is for you. If you look at this slide, look at the yellow highlighted line down towards the bottom of the screen. That's my personal email. So why did I give you that? Because you're not going to get all of this, and you're going to think, well, what did I forget? And I know you can go back to Modern and MicroDental, the labs, and thank God they're going to show this again, but I'm inviting you. You can write to me. I'm not going to sell you anything. I do this stuff because I really do care. I do, about my colleagues. And I'm at a point in my career where I get a lot of joy about benefiting you, and you writing to me telling me I helped you. So this is the kind of stuff you can get from me for this particular lecture. By the way, I can also get you the oral sedation protocol I haven't given you yet, all typed out. You'll get it in an email form. Medical clearance, like I have a great form that's crystal clear. Nobody can get confused as to what I'm asking them, the physician, the primary care physician for. Consents for medications. What do we use for implants, bone grafts, or extensive extraction surgery? My operative report, like the report in your chart or your computer, I can give you a beautiful guide to follow that makes it sound like the patient was done in a hospital. And it's the way you should document your charts and protect yourself legally. Post-op instructions, treatment planning options I'm not going to send you, but you'll get a bunch of stuff from me. So let's talk for a minute about the oral sedation. I want you to listen carefully to this patient. And look, he is on my regular regimen that you're about to get. Everybody needs to be on a monitor all the time. Now, I will tell you, that is not an exaggeration. That is exactly what this protocol delivers. It is astonishing. Now, do you need I'm going to go into it all, but you need a permit from your state. Get it. Oh my God, get the permit, because you're using more than one drug, as you're about to see. But that's the result you get. I work today. I have sedated, I can't even give you a real number. I know it's way north of 10,000 cases. You want to hear something astonishing? I've never had one complication, ever. I didn't have to call 911. The patient didn't react unusual to the medication, or I didn't know what to do. I never had to reverse the effects of the drugs. Never, not once. So that's a pretty, I had to call 911 once because I packed too much cord that had epinephrine in it. So the advantages of this, even if you chose not to do surgery, is that it encourages comprehensive care. So when you're in your treatment plan in your office and people are going to say yes to sedation, which, want me to shock you? This is going to generate a lot of emails. I don't charge them for it. The 3 pills I'm going to show you in a minute, the 3 drugs cost me $8 and plus nitrous. So there's 4 components to it. So yes, I pay for the nitrous. It encourages comprehensive care because nobody wants to get sedated and come in to have a 1DO composite filling done on number 12. So you group your procedures together. And remember, these are people that haven't been, you're going to attract people, patients, because I've been giving this lecture for 25 years. I mean it, 25 years. And probably less than 1% of you follow through and get it. I don't know why. Either you doubt my efficacy or you think something bad's going to happen. I mean, I think it would have happened by now. So scheduling, as I just said, you're going to do multiple procedures. So you're not going to be able to see or want to see 15 patients a day. These patients are under for 3 hours plus. Unconscious sedation is what I mean. And so naturally, you're going to see less patients. You're going to get paid up front. So it increases your cash flow because you can't reserve a 4-hour appointment for somebody and hope that they'll show up. They will show up if they paid you. So there's a lot more to talk about with that. But find out what your state board requires. They're different in every state. In the state that I'm in, New Jersey, it's 60 hours initially, and then 20 hours every 2 years. And it is worth, if they told me, whatever they told me, I would do it. So that's the drug. That's the money shot for you. 0.25 Triazolam, 50 milligrams of Atraumatic, 25 of Benadryl. What you may or may not know is that Atraumatic actually has an anti-anxiety component to it. And Benadryl obviously makes them sleepy. Add to that nitrous oxide, never exceed 50%. In fact, you'll start them at a mere 20%. And if they're really out of it, let's talk about that for a minute. Let me back up. I would only do ASA 1 and 2 patients. I would review all meds. You must do that. You must clear that. If there's any question in your mind about their medications and the drugs I just put up on the screen, then there's no exceptions. You have to absolutely, Either call the pharmacist if you don't know, use a pharmacology app. If there's any contraindication between Benadryl, Atarax, and Triazolam with whatever they're on. I have rarely been denied or changed my protocol. And if you're not sure with a pharmacist, then get a primary care physician to clear them. I'm going to be clear about something. I rarely have to do that. You can dispense it either in the office or you can write a script for it. We give the medication about 90 minutes before their appointment. And either they come into the office and they take it right there. And of course, you have to monitor everyone. If there's nothing else I gave you tonight, even though we are here to talk about, well, we're here to talk about 4 gems to accelerate your surgical extraction. And I wouldn't even dream of doing the procedure. I did this today, at least 2 or 3 patients. I wouldn't dream of doing it. And neither will you, of doing advanced surgery without some type of sedation. It's just too compromising. When they come in, you'll get them in 3 forms. Sometimes they're heavily sedated. And so you do need, and you should have a wheelchair in your office anyway. This is probably 10%. In other words, you'll go out to the reception room to get them and they'll be asleep. And you tackle them and they wake up and they get in a chair, you wheel them back. Remember, I'm going to say it again. I haven't even had anybody fall, like getting out of the wheelchair into the operatory chair or in the hallway or any place in 25 years of this. Moderately sedated is at least 75% of them. And they're pleasant. They're a little bit buzzed, funny. What we do with them is we put them on 20% nitrous. And most of them will begin to snore like you saw in that short video. And then there'll be some. I got 15% on the slide. I think it's less than that. And they'll tell you, I thought you said I would be sedated, or I thought you said I'd be asleep. So what do you do with them? I won't take the nitrous any higher than 50%. And I do give these patients very often a second 1 pill of Triazolam, not more Benadryl, not more Atarax. We crush it, we put it under their tongue, and it works much faster. It bypasses their GI, and that almost always works. But it will have a noticeable impact on their level of sedation. And you won't be using 50% nitrous on a patient that took 2 pills. Remember, I'm going to send you all this. What's the recovery, you should ask? I hope one of you does this and then writes to me. It's too good to be true, but I've done it for 25 years, so it is what it is. You put them on 100% oxygen, you turn the lights back on, because we turn the lights off for this. I got to tell you something. I'm all about lengthening your career and maximizing your pleasure of providing oral health care. This is a great, great way to do it. Imagine for a minute, my days generally are spent walking into a dark room with kind of cool music playing, like we all heard at the intro of this course today while you're waiting for me, and sitting down and doing what's been a treatment plan to do. And it's just, you should really look into this. Don't skimp on monitoring. Get yourself a quality. These are about $1,500 or maybe more. You're monitoring their systolic and diastolic, their pulse ox, and it prints it out. And again, how could I stand in front of hundreds of you or sit in front of hundreds of you and make this up? I've never had an incident. On occasion, their oxygen concentration, where it says 96, will drop to 90. You tell the patient to breathe. See, these patients are snoring, but they will respond to verbal commands. So if you say, you're going to notice that their blood pressure will go up if they have to go to the bathroom. And so maybe it's beeping, and you'll say in their ear, do you have to go to the bathroom? And they'll nod their head. This is a gift to you. I hope you take advantage of it. I don't want to spend much more time. Maybe less than 10% of them that you give that cocktail to will move their legs to the point, it's restless leg syndrome. And so we keep in the office ropinirole, and that works very, very quickly. Flumazenol is a reversal agent. So let me tell you something cool that some of you might like about reversal agents. So a lot of dentists are not trained to give it IV as they're required. I've never had to give flumazenol, by the way. I told you that. So look into this. Look into getting an atomizer in your office. So an atomizer allows you to put the IV medication in a nasal spray form, which has an identical impact on IV sedation. So you see, you're getting other tidbits here today as well. So look into, just Google atomizer. So you'll have that in your emergency medicine kit as well. Again, I've never had to use that. So let's talk about other safe practice habits that I want you to have. You should absolutely get yourself, I have it on the slide. You can, if you download Modern and Micro's lecture from me, you'll see the phone number. I have no connection with any of these companies, except it's what I use. It is what it looks like. It's a bag full of sponges that you throw away, and it stops things from going down their throat. Remember, they're sedated. So get it. Stella Life, if you're going to do surgery, let's say you're going to edentulate a patient, and that patient's a diabetic, they smoke, they are morbidities, are they not? That would delay healing. Look up Stella Life when you're done this weekend. And they make a pack, as you're seeing in front of me, of a rinse, a spray, and a gel that we give to patients 3 days before their surgery. That's when they begin it. And it's 4 days after. And it reduces swelling, it reduces pain. It's all natural, plant-based. It's not some fly-by-night company. They don't even know they're in my slide presentation. So I hope you understand my authenticity. This is genuine. This is what I use. Not on everyone, on a patient that has a morbidity that would delay their healing. So I'm going to skip that. So medical management. Here's my rule. There's more than enough patients for you. Don't take chances. A1s and A2s. I wouldn't even tell you to do third molars. I know I'm going to get a lot of hate mail for that one. But to me, there's no return on investment on third molars, because nobody here can argue on mandibular third molars. The geography of the mouth, the anatomy of the mouth lends itself to greater risk of neurosensory paresthesias, to larger vessels that may give you difficulty in controlling bleeding. For what? By the way, you can stay on good terms to some degree with your local oral surgeon. You know, if you're doing a lot of extractions all of a sudden, it'd be nice for him to still get the thirds. And by the way, don't just send him the lower thirds. Be a mensch and send them all 4. I don't sedate children. To me, somebody under 17 years old, under a body weight of 80 pounds, I just don't want to do it. And trust me, I've been in this 40 years. I am busier than I know what to do with, and so will you. Because when you market sedation, which is very easy to do, when you market sedation, people are going to come out of the woodwork. And most of your colleagues are not going to be willing to take the 60 hours or whatever it is in your state and get the permit you need. I can tell you, the same people in New Jersey show up every 2 years to get their permit renewed. It's a handful of us out of 9,000 dentists in New Jersey. And then if you're not sure, this is important. If I gave you no other medical guidance, ASA 1s and 2s, that means healthy people or healthy people controlled by medication. No children, just forget about it. And if you're not sure, then no. You know, all of us know that the age population of 85 years and old is the fastest growing population out of all of our patients. They're all on a myriad of medications. So that is not a place to go fast in your medical history review. You must know what these patients are on. There's current prescription use in the United States of 60 and older. 67% are on 5 or more medications and over the counter. You've got to take the time. You should not enter a surgery ever not knowing what medications they're on. I think you all are familiar on hypertension. I can tell you that the cutoff point is basically for most places that I'll advise you would be 180 over 100. They would tell you to abort. I don't personally always follow that. I will, but make sure that you do all of these vital statistics at the consult. Obviously, that you're going to go through this lecture. There's just people that are flat out no. Recent histories of angina, CVAs, congestive heart failure. I would stay away from people with a history of oral bisphosphonates. And of course, if they're on immunosuppressive drugs, some people should be treated in either a hospital setting or by a maxillary surgical office that is more prepared to handle these complications than even you are. But so what can you treat? Diabetes, of course, is just a tsunami of morbidity in the country. And so you've got to know this because you have to offset this and prepare the patient for possible delayed healing. I have a podcast, by the way. I'd love you to check it out. It's called The Lionhearted. I talk just like I'm talking to you right now about things that affect our offices every day. The Lionhearted Dentist. So let's get to the ABCs. What do we need to do? Well, first, this is what not to do. Watch the video. It's quick, I think. So you're going to see me go in with a forceps. And you're going to see me rock buccally, lingually. And okay, I get the first tooth out without too much complications. I'm having more trouble with this tooth. And in just a few seconds, you will see that I do get it out along with a significant piece of buccal bone. So this we will call the traumatic extraction, and that course is next month for people that want to learn how to build bone and have a lot of lawsuits. So don't follow that. So you're going to want to strategize. So what do I mean? You know, you're taking a tooth out that's got a buccal fistula. What's your sense of the bone density? What do you think the root anatomy is going to lend itself to? All right. So one thing I'm going to show you that if you were taking that crown out, the very first thing you do is you cut the crown off before you do anything else. So we know exactly where the tooth is. You know, do we need a flap? Well, we'll get back to that. The next line on this slide is as important as a lot of other things I've said tonight. You're going to want to know and have these two burrs, one from SS White, one from Brasler. You see the Brasler burr? That's the middle slide. That is what you're going to use in very tight quarters, and that's what you're going to use in the aesthetic zone when you don't want to touch the adjacent tooth. It's a very expensive diamond, and they burn up really quickly. I got that from Dennis Tarnow about 12 years ago. And if there's a better burr out there, I haven't found it. So, what's the restorative plan here? Is there implants? And I almost always graft just in case the patient chooses to have an implant and changes their mind. They might say to me, no way. Obviously, if they have periodontal disease, this is another problem, a different thing. The first step is to sever the fibers with either a 15C blade, that's what you're looking at on the top of the screen, or just with a Molt 2.4 elevator, which is on the bottom of your screen. Why is that important, even on a periodontally involved teeth? Have any of you ever extracted a tooth, like let's say number 30, and it looked like a piece of cake coming up? And, it wiggled, and you went to pull it, and as you extracted it out of the socket, it was still attached to the lingual tissue usually. And then you tear the tissue, and it requires suturing, and you're tearing up the patient's mouth. No matter how easy it is, just take 30 seconds and release the 12 different fibers attached to every tooth. Now, the goal in the next 5 or 10 minutes is to master these principles, but when you can keep it simple, let's keep it simple. So this is a simple demonstration of a simple approach to removing this tooth that's got a periapical abscess. And the reason I'm taking this approach is because of the shape of the root. I teach many courses on how to section teeth, the hardest teeth you can think of. But when you don't have to make it complicated, then don't. The patient appreciates that. The body appreciates that. So what you see me doing now is just severing fibers. You always want to do that no matter how easy the tooth may or may not be. This one's not periodontally involved. It just has a conical shaped root that should allow me to elevate it rather easily, as opposed to going through, sectioning it and all that kind of protocol that I normally advocate. And you'll see, remember, the bone loss, I'll show you the x-ray, hopefully, is mainly on the distal. So you notice that I'm holding this, I'm not moving. I'm expanding the bone by doing what I'm doing now. That's been over 10 seconds, so I find it difficult for most clinicians to be that patient. Most clinicians like to turn like this constantly. It's really one movement. I'm pushing apically, and I'm lifting the tooth pretty easily now because I already expanded it. So I just showed you the 10-second rule. That's what it was. I literally was on that 10 seconds. When I say on at 10 seconds, I am torquing that tooth. I am pushing hard apically and turning my elevator so that it lifts the tooth up. And I can get away with that on that tooth because it had a conical shaped root, because I strategized. I looked. Strategize just means step back for a second. Don't go in like a cowboy. What do I have here? Because if it wasn't that, if it had divergent roots, we're sectioning that tooth. We're not even going to play around. Listen to the tooth and it'll tell you what to do. I always say that in my courses. And if it breaks as you're trying to get it out, it's telling you you didn't trough enough, or that you didn't use your luxator properly. And we're going to get to in a second what troughing means. The most important skill for you to acquire, and nobody can kid you on this, it just takes some time, is that are you moving the whole tooth like you just saw in the video, or are you bending the root? And believe me, when you do a few dozen of these, you're going to know that feeling. You already know it. You know when your blood pressure drops because you know you have the tooth. It moved. The whole thing moved. You didn't just move part of the root that's about to snap. Learn to be methodical. Like if you're taking out a bunch of teeth, I'll show you what that means. You're going to have a purpose for every move you make. Do I have vision, access? Have I troughed? I'll explain that in a second. So this is a close-up of the diamond that you trough with. So a trough means that you create a space adjacent to the root. Remember this, there's a lot of information for you, but some of you who have already delved into surgery will benefit greatly from this if you're struggling from time to time. So a trough is created in the space adjacent to the root. And remember this, all the bone that you take away to create the space between the buccal and the palatal wall, you never take away buccal bone. You only go between the buccal and the palate, or in the mandible, the buccal and the lingual. And you go all the way down the depth of this burr. You will not hit, I've done the studies, you're not going to hit any anatomy that's going to harm the patient. Okay, just stay with me. In that space you created, you're going to put your elevators, and then you're always going to turn and put apical and turning away from the buccal wall type of pressure. This burr you're going to use in posterior areas, okay, where it's a workhorse. The diamonds are very expensive, but you need them. And you need like expensive, I think they're at least $10. And you could use one in one surgery, or you could use 4. So they're the burrs. Again, I can't give them to you enough. In the state of California, you can't use a high-speed drill. You have to be use an implant type of drill that's got a contained water system. I don't know about all the other states. This is the only state I know this. Something must have happened out there that warranted the board instituting this rule. The thought is, don't I cause an air emphysema? And would it be better to use a rear-ended, absolutely, rear-ended vacuum on the drill, or even a contained water source? Yes, but I've used high speeds for 30 years with no air emphysema. So remember something, when maybe you ought to practice this a little bit, because you're not going straight down. You're following the roots with these burrs, and the roots are conical. So here's the question you're all going to ask me. Exactly where do you place the burr? The answer is right between right up against the root. And it doesn't matter if you take some of the root as you're creating this trough. You'll get skillful enough that you'll be able to feel that you're on bone. And you're doing it in that first slide that I started this seminar with. You're going on the mesial and the distal. And it's also very effective with maxillary delicate molars, with the mesial buccal root or the distal buccal root. How deep do you go? The longest, this burr that I'm showing you is only 21 millimeters. And there's literally studies on how long teeth are, and go the full depth of the burr. You can't go any further than that. So one of the things you're going to do, and I want you to take this in, is if I was taking this tooth out, which I did, the very first thing you do, remember I said be methodical? Okay, so being methodical means you open your contacts first. Okay, how could you possibly see the mesial or distal of this tooth the way it is right now? How would you see where the root emerges out of the gum? So I'm going to teach you something. There's 2 things to do. Decarinate the tooth. It sounds counterintuitive to those of you that use forceps, because what are you going to grab with the forceps? You're not going to grab with the forceps. We're going to make the tooth so loose with elevators that you could take it out with college pliers. So you decarinate so you can get down further on the root. So you'll see me do this right now. I'm down to about 10 minutes with y'all, so I'm trying not to go fast. I want you to get these points. So literally, if this patient was in my chair, the first thing I'm doing is I'm opening up with just a diamond, the meso and the distal, so I don't mess with the adjacent teeth. I don't want to hit them with my elevator. I don't want to touch them with my drill. The next thing I would do with this tooth is I would take the crown off with a drill. I'd literally cut it off with a drill. See, this is what decarnating is. This allows me to get the burr down the root further because I'm not stopped by the incisal edge. You should feel the burr. This shows you what I'm talking about right here. So you usually go in on an angle. You start out like that. And I'm taking out maybe 3 or 4 millimeters on an angle. And once I get an angle, you'll see me straighten up the burr and go in on this conical root to as far as I can go, creating a trough of which you can see it there right now, where I'm going to insert an elevator. I love luxators. That's what I use 90% of the time. And I'm going to put the luxator in that slot, turn the luxator so the tooth goes away from the buccal. So it's pressured towards the lingual or palatal so I don't break the buccal bone. An atraumatic extraction means that you take the tooth out and you have 5 walls of bone left. So interradicular bone always grows back. Never go through the buccal or the palatal or the lingual wall. What if you did? Patient's not going to die. You're going to have a defect that won't grow back unless you use a membrane. Just take your time. Let me teach you something else. My last podcast on the Lionhearted was entitled, Give Yourself More Time, on everything. If you would give yourself an hour to do a surgical extraction, give yourself an hour and a half. Charge enough. Remember, it's an atraumatic extraction. Not everybody can do that. And you'll never, ever go broke because you gave yourself more time. In fact, you'll have less redos, less complications, more connections, more peace of mind. Don't get me started. Give yourself more time. So it's all about creating these fulcrums by creating sloths for these new age elevators. There's the concept of creep I talked about 30 minutes ago. This is what I used for 20 years. And then luxators came out and all kinds of, there's even more. Salvin has these very small periotomes for hard to get to areas. That's what the luxators is. Only 4. It's not a big investment for you. The 10-second rule, it's really hard to implement. Most of you, for some reason, like to keep turning the elevator. Right? Ask me how I know. I give live courses in my office, which I'll tell you about right before I'm done, which is in about 5 minutes. So, what about bone grafting? What the heck do you put in the socket? Demineralized, mineralized, collar plug, nothing. I mean, there are studies for everything you can think of. Here's what I would tell you to do. I swear this is another gem that wasn't listed in the beginning. Get yourself a camera. I mean it. Take a pre-op. Take a post-op when you're done. Get a clipboard or your computer and document the date, the time, and what you put in there, because you should try different products. I'm going to tell you what I think you should use, and so try it. And then take a photo at 12 to 16 weeks and see what keeps looking good. Are you kidding me? Why wouldn't you do that? So, all combinations of grafts, just remember this slide. They need something in the socket and they need adequate blood supply. So let's review. What I tend to use is a 50-50, which is a lot of surgeons use. I'm a GP, by the way. When I say a lot of surgeons use it, Mike Picos from Tampa, Florida, who teaches GPs, periodontists, oral surgeons. They tend to use a 50-50 mix of cortical cancellous bone. Many companies supply this. The one I tend to use is from BioHorizons, because y'all tend to go to companies. By the way, remember, you can ask me any of this. Even when you download the lecture and go back over it again, don't panic right now. We'll get back to you, or Beth, my administrator of the Rasner Institute, will get back to you. What do you put on top? That's collagen. Everything you put on top, the different choices you have, last a different amount of time. So it really depends on what you're trying to achieve. In most cases, this is important, with a 5-wall socket, you understand that means you didn't lose any walls during the extraction. It means that they didn't lose any walls from an infection, which often happens. You come in with a buccal fistula, that buccal wall is gone. That's a different approach. That requires a flap, and there's only so much we can talk about in this one lecture. So you always suture in your collagen that's on top of your graft. And 16 weeks from now, you can put an implant in there, or if you were doing a bridge, you will have a very nice pontic site. That's the mixture I use. Again, other companies offer the exact 50-50 that I'm talking about. I have to tell you that this is important. They say that the half-life of this kind of information I'm giving you is 2.5 years. That if you go back 5 years ago, everybody was using what's called PRP. When I'm talking about when you draw the patient's blood and you use the membrane for a graft, which is a beautiful thing in the aesthetic zone. Well, today it's PRF, platelet-rich fibrin. The same here. I make changes and I document it. So right now I'm using 70% of this slide, 70% of minerals. So if I used a whole bottle, I would use 30% of Minerals X, which is a xenograft. All you got to do is look up xenograft, use the company you're comfortable with. So that's what I use. There's my conclusion, 70-30, socket seal, bam. This is a socket seal with PRF that you're looking at right there. It doesn't get any better than that. And I can tell you exactly how to get to that. This is a pretty state-of-the-art socket seal. You're looking at the patient's own plasma membrane. You're looking at Resolon suture, which it has to be removed. It's non-resorbable. It doesn't collect and attract bacteria. There's reasons for everything you do. Sometimes I do a free gingival graft, and that's my socket seal. So you can see, if you like this lecture, I get it from the tuberosity, by the way. That came from the tuberosity with just a punch. And this is the last one I'll give you. This is a membrane that is also non-resorbable, and it's a dense PTFE. The beauty of this membrane that you're looking at is that you don't have to get primary closure. So it's a beautiful thing. So you'll have to ask MicroDental and modern dental labs if you want to have more of this, because we probably need 5 of these. And that's my recommendation for our next webinar. So what to do with bleeders, what to do with sinus perfs, what to do with lack of visibility. Okay, so I am looking for my questions. And
I
one
believe
question
answered a couple for you.
Oh, okay.
Let's see. It had to do with what is Atarax?
Okay, Atraumatic is an antihistamine, yeah. It's an antihistamine.
Mm-hmm.
Okay.
And then we encourage questions. So if you guys have questions right now, it's the best time to ask. And Dr. Rasner will answer them for you. Let's see.
I'm going to give you one until I see one.
Okay.
Because it's a good one.
Okay.
What do I do if I'm in the middle of an extraction, Steve, and I'm stuck? Okay. Here's what you don't do. I don't know Let me finish this one question. This is important. Like, how far do you do it? It's happened to me. It's probably happened to anybody. Like, how far do you go with a tough tooth? Is there a need to finish the process? And the answer is no. I would have to tell you somewhere between 40 minutes or more, I would be done. What you don't want to do is torture this patient with breaking off root tips because you're stuck for 2 hours because you're embarrassed. It is okay. Some teeth are hard to get out. I had a hard time with one just last week. I don't know why. Had roots longer than Godzilla. It was really tough. And it is okay to pack it up. If you have to suture. Make sure it's below at the level of the gingiva, and simply tell the patient, you know what? You're my most important priority. Sometimes we get in a side of a tooth and it's just too tough. And I'm going to stop today. You will be the better for it. I used to think that if you didn't finish, who knows, the patient I don't know what I thought. You don't have to. I'm not encouraging you to do that all the time. I'm saying if you really get stuck. By the way, before I forget, I have the coolest thing for you. You got to go on to RasnerInstitute.com. So if you're a dentist with a license in any state, you can come to my courses, which we have 4 times a year. We have extraction courses and implant courses, and you can practice skills that I'll teach you live on patients. You're not watching me. You are doing it with me over your shoulder. I am literally holding your hand along with 2 other proctors that I have. The classes are very small. I'm not going to kid you. We have September and November courses. We have like 2 spots open in each course. I am not telling you that. And if you knew me, you would know that's true. I am not telling you that to sell you. I'm maxed with them. But it is an amazing opportunity. Those of you that have been through a didactic implant program and never got to practice, you don't have to go to Central America. You can do it right here in New Jersey. We even anesthetize the patient for you. I numb them so you don't have to waste your time and be worried whether you missed a block or not. You walk in, sit down, I come in and say, do this, this, and that. I'll be back in 5 minutes. It's cool. So check it out at the Rasner Institute, or write to me an email and I'll give it to Beth. Okay, another question. How do I feel about physic forceps for atraumatic extractions? Okay, I hope you're not the owner of the company, but I hate them because they break off buccal bone. They exercise in principle the concept of creep that I told you about. Maybe it's me. Maybe I have bad hands. I don't know. I have found many clinicians to echo what I've just said to you. Yes, the tooth comes out. And often, if the buccal bone is not thick, that also comes out. And that is a drag, because then you got new procedures that now you have to do that you're probably responsible for to do. So I'm not a big fan. That's the truth. I am a big fan of the man who invented them, which was Carl Misch. So what about, excuse me, I'm sorry.
There's one more question in the chat window too.
I don't see it. I see the
says,
physics one.
Any tips on extractions of max primary molars for ortho besides sectioning where the roots are not resorbed?
Yeah, okay. So we're talking about a teenager generally. If we were talking about a teenager, I would be okay in that instance of severing the fibers, and I would use a forceps very carefully, buckle 10 seconds. Try the 10-second rule, my friends. You're going to love it. Back to the palate, okay? That is the only way. But count in your head the 10 seconds, or count out loud, and your assistants will think you're weird. I am telling you, it seems like an eternity, but it changes everything. You really need to try that. There's no doubt about it. Now, if they were an adult and getting ortho, and depending on their density of bone, I probably would section, because the last thing I want to do is bust off block. It would depend. I would strategize. How long are these roots? Do they have dense bone? you know, a lot of things would go into it. And then some of you might be wondering about suturing. Real quick, nobody will ever tell you this. Here's how you learn how to suture. Go Google some models to practice on that are silicone. Order those models, take some suture home, go on YouTube, and the techniques that you want, obviously, besides interrupted, are continuous locked, horizontal, and vertical mattress. That's all you need. A sling's nice to learn also. And you practice. There's a million YouTube videos out there, and it just takes time for you to do it and overdo it and do it again and again, and then you'll get really good. That's how you do it. Got anything else for me?
No other questions as of yet. I mean, people, if you have any, go ahead and
Here's a little one for you. Why wait?
Okay.
What if I break a root tip and I just can't see? Flap. Now you may say, I don't know how to flap. Yes, you do. All of you know how to do a sulcular flap. So flap one tooth in front and one tooth in behind the site you're going in. And this is what I always teach my doctors. Your flap doesn't know how big it is. So if you make it one tooth or two teeth, it still takes the 21 days or whatever it is to heal. So you never can really go wrong once you flap by extending the flap as opposed to making a micro flap, meaning too small, and torturing the tissue and tearing the tissue. So just sulcular flap means a 15C in the sulcus of the adjacent teeth to the tooth you're working on. And as soon as you do that, remember me telling you this, you instantly can see. It's amazing. But I'd start out without flaps, quite honestly, unless I knew I had a buccal fenestration that I knew I had to repair, and that's not the scope of this present podcast.
Okay, I think we're gonna close it off now. I don't see any more